Hello, everybody. Thank you for coming to another of Renew's webinars. We're celebrating Physical Therapy Month for the month of October, so we were hoping to give back to some people and educate you a little bit more on some conditions. Hopefully, we can help you with a little bit of extra information, and maybe down the road we'll be able to help treat you with any of the issues that we may be talking about. My name is Jessica Van Soest. I'm a physical therapist and clinic director at Renew Physical Therapy in Oakland. And today we are going to be talking a little bit about benign paroxysmal positional vertigo, or BPPV, and concussions, and a little bit of vestibular rehabilitation. So these are two very different things. I know I'm kind of putting them together in one little presentation, but I just want to touch a little bit on each one, kind of separate them into two different areas and kind of understand what they are, how we treat them, and kind of what the expectations would be going in, and kind of separate that difference, okay? So first, what we'll get into is we'll start to talk about BPPV, which is that benign paroxysmal positional vertigo. This is the thing that a lot of people have heard about, where basically you have the symptoms just kind of come out of nowhere and your world is spinning. So BPPV itself is when the little crystals called autoconia are dislodged from the inner ear. And now I'm going to pull up a screen that kind of shows you an image of that just for a moment here. So we're looking at the inner ear here. You can see the ear coming onto the inside. So this is where we want those little crystals to be sitting. But sometimes what happens is they become dislodged and come into these semicircular canals. So for future reference, when I'm talking about that, that's what's happening, is they're going into these three. There's the anterior, lateral, and posterior. The lateral is also called the horizontal, so you'll hear me talking about that a little bit later. So what happens once those autoconia are dislodged into the ear? There's not really always a reason for why this happens. This is very spontaneous. It's an insidious onset, so it's not necessarily a known cause. You can have predisposing factors such as migraines, diabetes, other things that can kind of make it more common for you. But in the long run, there's not really a cause of BPPV. The most common symptom that you'll notice, though, when you have BPPV is vertigo. So vertigo is going to be a little bit different from dizziness. Dizziness can mean a lot of different things, where vertigo itself is basically if you move into a certain position, all of a sudden it feels like the world or the room around you is spinning. So it's not just that you're feeling lightheaded, it's that everything seems to be moving. This can make you feel uneasy. It can make you feel a little bit nauseous. There's other symptoms that kind of correspond, but that full feeling, if you're looking at the floor and it looks like the carpet is a river, that's kind of that vertigo. So it's a very specific feeling that you'll get with BPPV. Usually with BPPV, those spells will only last a couple seconds. This is going to be opposed to other vestibular conditions such as Meniere's disease or vestibular neuritis. Those spells are going to happen a lot longer. They're going to be minutes to hours. So there is a very strong difference between the two, which might help you kind of figure out what alley you might be in. A lot of the times we're going to diagnose BPPV. You can be going to an audiologist, an ear, nose, throat doctor, or come to physical therapy, where we're going to be basically doing a specific positioning maneuver to test. So this is called the Dix-Hall-Pike maneuver. When we do this maneuver, you're going to be going through a series of motions in which we're trying to stimulate your symptoms. What we are looking for as physical therapists is what's called nystagmus. It's going to be this kind of rapid eye motion that happens as your brain is trying to understand what's happening in your ear, telling you that you're spinning when your body really isn't. So you're going to have this information processing that's not necessarily matching up. And that's why your eye is going to be moving even though your body is holding still. So we're going to be taking a look at that, and that will kind of tell us which ear it's happening in and also help kind of guide our treatment. Treatment for BPPV is going to be a very similar position maneuver, where a lot of the times for the posterior or anterior canal, We're going to be looking at the Epley's maneuver is the most common, but there's a ton of different maneuvers that we can do if that one has not worked for you in the past. And then there's the barbecue roll, which sounds a lot more delicious than it is. And that's going to be working on the horizontal roll, the horizontal canal. The horizontal canal is less common, but it also can be a lot more intense or disruptive to people. So generally, we're going to be seeing the posterior canal in most people. But after these treatments are done, the beauty of BPPV treatment is that usually we can treat you in one session and you will have a very good experience after, because you can treat BPPV in almost one time. Usually we'll follow up with you, but BPPV is basically our goal with the treatment is to be able to flush those those otoconia out into the utricle, which is that inner ear. So we're basically flushing it out to where they belong so that they can get reabsorbed and don't initiate that motion anymore. So if done right, the proper treatment for BPPV is quite quick, and you'll only have to see us once or twice, which is really nice. So that's a lot about BPPV. At the end, we'll kind of do a little recap, but we're going to get into concussion now. So take off that BPPV cap. We're moving into concussion here, which is a different kind of beast. So when we're talking about a concussion, we're talking about a type of a traumatic brain injury, or a TBI. It's caused by a blow to the head or the body. So anything that can cause a vicious forward back motion of your brain within the skull, creating injury to the brain. When this happens to the brain, you're going to get what's called a metabolic cascade. It often occurs resulting in an energy crisis at or a chemical imbalance at a cellular level. So a lot of the times when we're thinking about concussion, it's metabolic more than it is an actual injury or a structural injury to our body. A lot of the causes of concussion are going to be motor vehicle accidents. So if you think about the forces that happen when you go through a whiplash motion, you can be getting them with that. Falling, so slip, fall, and you hit your head, that can be a cause of a concussion. Sporting, we hear about concussion all the time in sports, so you're going to be seeing them. Any type of impact, but it can be something as easy as just once again falling on ice or something like that, or a blow to the head. The symptoms that come with concussion are going to be way bigger and more vast than we would have had with BPPV, with vertigo being that primary symptom. In concussion, you're getting dizziness, fogginess, nauseousness, difficulty concentrating, emotional liability, so feeling like an emotional roller coaster, sensitivity to light and sound and motion. So you've got a big spectrum of different symptoms that you may experience. You may not experience them all. You may experience them at different levels, and they may change day to day, which makes it really difficult to recover from a concussion at times, especially if it's not your first one. Diagnosis for concussion is not as simple as BPPV, where we kind of do a little positioning with you. It's something that's kind of known just due to your mechanism of injury, kind of what you're telling us. If you have a baseline measure with certain, usually with more elite sport or youth sport, you may have a subjective questionnaire that you've previously filled out called a SCAT. That's the only time that we're going to be able to have your baseline measurement of what your normal is. And without that measurement, it's going to be hard for us to know exactly what has all been impacted for you. And so with concussion, it's never going to be that, oh, it's a quick diagnosis as exactly what's going on. But oftentimes we'll understand that this is the case, and we'll know how to treat it accordingly to the symptoms. When we do our actual treatment, what we're going to be doing is it's going to be a similar treatment that we would do for some of those vestibular disorders that I was talking about earlier, the vestibular neuritis and the Meniere's. Those ones you're looking more neurological in nature. When we're talking about concussion, it's going to be more chemical in nature, but it's the same information processing. When we're treating concussion and vestibular and some of those other vestibular conditions, we're treating the brain. We're not necessarily treating the injury itself. We're treating the brain and being able to get that information processing to be functioning at a regular level again. So to do that, what we have to do is what's called vestibular rehabilitation therapy. A lot of big words. And like I said, which goal is to retrain the brain. Using the vestibular rehabilitation therapy, we push into the symptoms, hoping for 3 different things to kind of happen. We've got adaptation, substitution, and habituation. When we're doing treatments with VRT, it is not a comfortable thing. A lot of the times we have to provoke those symptoms. We're going to put you into a place where we're causing you to shake your head and look at something. We're going to get you moving around, making those symptoms kind of occur. So it's not the nicest thing that we could ever do, except for it's effective. Adaptation, like I said, you're going to be doing head shakes. We're going to have targets, things like that, starting to work on that eye head movement and syncing those sensory responses so that we can help train the brain to be able to relearn that connection and not feel a disconnect between what's happening at the vestibular level or what's happening at the brain level and what's actually happening with your body. Habituation, we're going to have you on a ball, maybe getting you moving on wobble boards, things that are going to cause you to move, or getting your body swaying through motions and getting your body to get used to these motions. We need to do it longer periods of time and ideally get you into more vigorous and more dynamic motions to get your body used to it. Sometimes it can be just like a busy environment that we need to get you in to get you used to some of these, but it's going to be a very graded level. So it's not as quick as the BPPV. It's going to be taking weeks, usually sometimes months, for these kind of symptoms to start to go down. The last one is substitution. So we're looking at using the 3 different parts of equilibrium. We've got our vision, we've got our vestibular system in the inner ear, and then we've got proprioception, which is kind of in our joints that help us with balance. What we'll do is we'll either start to help train the vestibular system by taking those other 2 options out, getting you to close your eyes while you're balancing. That's going to be 70% of your ability to balance is taken away. So it really stresses those other parts of your body. Or we'll put you on a foam block so your joints can't tell you exactly where you are and kind of use those. Or we're training those other parts of your equilibrium to help balance out when your vestibular system may not be working as well. Basically, using these 3 processes will be able to help improve the coordination of the head and eye movement and return you to that equilibrium over time. So looking back, BPPV is going to be more so that vertigo, world is turning on you, very sudden onset with no cause. And then we've got concussion or some of those more vestibular conditions, which are going to be, they may be caused by a specific injury or an illness or something that you have longer episodes and the treatment is going to take a lot longer. Like I said, all of these are treatable with physical therapy. One's going to be a lot faster with the BPPV ideally. Other ones are going to be taking a little bit longer, but a lot of the times we are able to treat these things. It's hard when you're talking to people about them because they're things that you can't see. It's not like you're walking into a room and you have a knee brace on, or you're in crutches, or you have a wound or a scar to show. So these are always harder for people to sometimes talk about or get others to understand. So it is definitely important to kind of get that treatment and make sure that you find someone that can understand what's all going on and how to properly treat this to kind of get you moving in the right direction. Because a lot of these, if left untreated or not pushing yourself into being able to adapt to these situations, can go on for a long time. So seeking out treatment is often a really important part. And like I said, there's different ways to make sure that you get in contact with a therapist that can help. But generally there's a way that we can help you out and get you moving in the right direction. And that's all I have for today. We are going to be offering some screenings. If you look in the chat box, you'll be able to see my email. So if anybody is interested in giving me an email, letting me know if you're having any of these symptoms, don't hesitate to go in. We also have our admin email on there. If you want to schedule an appointment, all of that information is going to be in the chat box there. Hopefully you guys all enjoyed this segment and maybe learned a thing or two. It is a complex thing, so hopefully we'd be able to talk a little bit more so and get you to see what's all going on. Thank you guys for joining us.